Welcome to another episode of SurgiSmart Cut to the Core. I mean, imagine knowing with, well, absolute certainty that your body is just physically missing the microscopic proofreaders designed to stop cancer before it even starts.
Yeah, it's a really heavy burden to carry.
Right. And for decades, a diagnosis of what we now call Lynch syndrome was practically a death sentence. It was this, dark cloud hanging over entire family trees.
It absolutely was.
But today, it's a solvable puzzle. So, welcome and thank you for joining us on this special deep dive. Whether you're a medical professional catching up on the rapidly shifting landscape of precision medicine or, an FRCS candidate prepping for a major surgical exam.
Or even just an insanely curious learner who wants to understand the absolute cutting edge of hereditary cancer management, you are definitely in the right place.
Exactly. Our mission today is ambitious, but entirely achievable. We're going to equip you with the definitive, most up-to-date roadmap for identifying and surgically managing Lynch syndrome.
And to do that, we are synthesizing a truly massive stack of high-yield sources today.
Oh, massive is an understatement. We're pulling from the latest European guidelines from the European Hereditary Tumor Group, or EHTG, and the European Society of Coloproctology.
Plus, we're parsing through the detailed EviCore lab management guidelines, primary care data from the Wessex Cancer Alliance, genetic testing protocols, and the absolute latest gynecologic oncology updates.
That's a lot of material.
It is quite the stack of literature, yeah. But wading through it is incredibly important. As your guide through the clinical weeds today, my goal is to really help you connect the dots between the raw data and the actual human being sitting in the clinic.
Which is the most important part, really.
I think so, because my core belief when looking at all of this complex genetics is that knowledge is most valuable when it's practically applied. And in the context of Lynch syndrome, applying the right knowledge at the exact right time literally prevents cancer.
Yeah.
It alters the trajectory of a person's life entirely, taking them from a state of passive fear to active prevention.
Okay, let's unpack this. We have to start by clearing up a bit of an identity crisis, because the terminology in this field has been a mess for a long time.
Oh, completely.
Historically, the medical community referred to this condition as HNPCC, which stands for hereditary non-polyposis colorectal cancer. But you rarely hear that anymore.
No, almost never. Now we almost exclusively call it Lynch syndrome.
Right, named after Dr. Henry Lynch, who systematically characterized this syndrome back in, I think, 1966. And he was actually building on the foundational work of Dr. Aldred Worthen way back in 1913.
That's right.
But before we get into history, let's ground ourselves in the biology. What exactly is this condition at a microscopic level? Because the sources defined Lynch syndrome as an autosomal dominant genetic condition. Can you translate that for us?
Yeah, let's break that down. So autosomal just means the gene mutation is located on one of the non-sex chromosomes.
Meaning it affects men and women equally, right?
Exactly. And dominant means you only need to inherit one broken copy of the gene from one parent to actually have the syndrome.
So it's basically a coin flip.
Literally a coin flip. If a parent carries the genetic mutation, each of their children has a 50% chance of inheriting it. And the biological root of this condition lies in defective DNA mismatch repair genes.
The MMR genes.
Right, the MMR genes. You'll constantly hear us refer to them that way. Specifically, we're talking about four main genes: MLH1, MSH2, MSH6, and PMS2.
But there's a fifth one too, isn't there? EPCM.
Yes, EPCM is the fifth player here. Now, a mutation in EPCM doesn't directly break the mismatch repair system itself. Instead, it causes what we call upstream silencing of the MSH2 gene.
Upstream silencing. So it basically turns it off.
Yeah, exactly. It acts like a roadblock. It shuts down MSH2 and effectively knocks it completely out of commission.
I want to make sure I'm visualizing this correctly. The mismatch repair genes, they act like a molecular spell checker, right?
That's a perfect way to look at it.
Because every time a cell divides, the body has to copy, 3 billion letters of DNA. Naturally, the copying machinery is going to make typos.
Unavoidable typos, yeah.
Right. And if these mismatch repair genes are broken, the body loses its ability to fix those everyday typos. And when those typos accumulate exponentially, the cell goes rogue and cancer develops.
That's the exact mechanism.
And classically, this presents as early onset colorectal cancer, with the mean age of diagnosis sitting somewhere between 44 and 61 years old, depending on the specific gene involved. But going back to the name, the term HNPCC really does the syndrome a massive disservice, doesn't it?
A huge disservice.
Because it implies it's just about the colon, and it implies there are no polyps involved.
That is precisely why the term HNPCC fell completely out of favor.
Yeah.
I mean, it's wildly misleading. The sources highlight this beautifully.
How so?
Well, first of all, it is absolutely not just about the colon. It's a systemic vulnerability across the whole body. And secondly, it's not always non-polyposis.
Meaning they do get polyps.
Right. We used to think these colon cancers just sprang up out of nowhere without a precursor polyp. But gathering evidence suggests that in patients carrying the PMS2 variant, for example, carcinogenesis, which is the actual biological birth and development of the cancer, happens predominantly via the adenomatous pathway.
Wait, hold on. The adenomatous pathway. For the non-gastroenterologists listening, you mean they do form standard polyps, the adenomas, that eventually turn into cancer?
Yes, exactly. They form the exact same type of precancerous polyps that the general public forms.
So the non-polyposis part was just wrong.
Completely wrong in many cases. The
Yeah.
difference is the speed at which those polyps turn malignant, which we will definitely dive into later.
Okay, good to know.
But regarding the extracolonic cancers, the cancers outside the colon, the list is incredibly extensive.
Yeah. What else is on that list?
We're looking at a highly elevated risk for endometrial cancer, which is the lining of the uterus. In fact, endometrial cancer is often the sentinel cancer in women.
Sentinel meaning it's the very first cancer to appear.
Exactly. It acts as an early warning sign for the syndrome. Beyond that, there's ovarian cancer, gastric or stomach cancer, cancers of the small bowel, the urinary tract, the hepatobiliary tract, the pancreas, the brain-specifically aggressive tumors called glioblastomas, and even certain skin neoplasms like sebaceous adenomas.
Wow. So if a patient has this broken spell checker, the symptoms they present with could come from almost anywhere in the body.
Really anywhere, yeah.
For the gastrointestinal side, we're taught to watch for blood in the stool, unexplained changes in bowel habits like sudden chronic constipation or diarrhea, and, unintended weight loss.
Classic GI red flags.
Right. But equally important, especially for female patients, is abnormal vaginal bleeding. A patient coming in with irregular bleeding between periods, or especially bleeding after menopause, is presenting the classic symptom of endometrial cancer.
That's a crucial thing to catch early.
Absolutely. Now, before we had cheap genetic testing, identifying these patients relied heavily on clinical family history. We had these rigid sets of rules, namely the Amsterdam II criteria.
Yes, the classic 3-2-1 rule.
Let's review that for the exams.
For the Amsterdam criteria, you needed to have at least 3 relatives with a histologically confirmed Lynch-associated cancer.
And histologically confirmed just means a pathologist actually looked at the tumor under a microscope and verified exactly what kind of cancer it was.
Right, no guessing based on family rumors. Furthermore, one of those 3 people had to be a first-degree relative of the other 2. You needed at least 2 successive generations involved, like a father and a daughter, and you needed at least one of those cancers to be diagnosed before the age of 50.
It's very specific.
Very. Amsterdam, I focused just on colorectal cancers. Amsterdam II expanded the net slightly to include those extracolonic tumors we just mentioned, like endometrial, ureter, and small bowel cancers.
I always think of the Amsterdam criteria like a VIP club bouncer who is just way, way too strict.
Oh, that's interesting. How so?
Well, imagine a patient walking up to the club. They have a family history of colon cancer, but maybe their family's just small. Maybe they only have one sibling and their parents were only children, or maybe people in their family passed away from other causes before cancer could develop.
Right, like an accident or something.
Exactly. The bouncer looks at their short family tree and says, "Sorry, you don't have 3 affected relatives across 2 generations. You don't meet the 3-2-1 rule. You can't come into the Lynch syndrome screening club."
Yeah, that makes sense.
The bouncer is turning away people who actually belong in the club simply because their family tree isn't physically large enough to generate the required data points.
That is a brilliant analogy, and it explains exactly why those criteria were so heavily flawed. But we do have to understand why the bouncer was so strict in the first place.
To avoid overtreatment.
Exactly. Back then, we didn't have a simple blood test to confirm Lynch syndrome. If a patient met the Amsterdam criteria, doctors often recommended radical, life-altering surgeries, like removing their entire colon purely based on that family history.
Oh, wow. So you couldn't just guess.
No, the criteria had to be incredibly strict to avoid performing unnecessary total colectomies on people who just happened to have a few cases of standard random colon cancer in their family.
That makes sense. But the collateral damage must have been high.
Massive. The clinical criteria used alone missed between 12% and 68% of actual Lynch syndrome cases.
Up to 68%. That is wild.
It is. Up to 39% of families with confirmed genetic mutations do not actually meet the Amsterdam criteria. Even the revised Bethesda guidelines, which came later and shifted the focus slightly toward testing tumors based on specific age cutoffs and pathological features, still miss a highly significant portion of patients.
If these clinical criteria miss up to 68% of cases, we are essentially relying on a totally outdated map. Why are we interrogating the family tree when the tree is so obviously incomplete? Shouldn't we be looking directly at the tumors themselves?
This raises an important question. And the answer from the latest European guidelines and the EviCore lab management pathways is an unequivocal yes.
So we're moving past the bouncer.
The paradigm has completely shifted. We are moving away from relying solely on family history and moving towards the modern gold standard, universal screening.
Universal meaning everyone.
Everyone. The guidelines now strongly recommend that all colorectal and endometrial cancers, regardless of the patient's age or how big or small their family tree is, should be tested for evidence of mismatch repair deficiency right at the time of surgery or biopsy.
Let's walk through exactly how that is done, stepping from the tissue level down to the genome. This is a massive, high-yield area for FRCS exams and clinical practice.
It's basically the core of modern management.
According to the EviCore algorithm, this universal screening starts with either immunohistochemistry, known as IHC, or microsatellite instability testing, known as MSI. I know these terms can sound like alphabet soup, so let's break them down clearly. What are we physically doing to the tumor in the lab?
Let's start with immunohistochemistry, or IHC. This is essentially a specialized dye test. The pathologist takes a microscopic slice of the tumor tissue, puts it on a slide, and applies specific chemical stains designed to bind to the 4 mismatch repair proteins, MLH1, MSH2, MSH6, and PMS2.
And if the genes are normal?
If the patient's genes are working normally, those proteins are being actively manufactured by the cells, and the stain will show up bright and clear under the microscope.
Right, but if there's a mutation?
If a gene is mutated and broken, the corresponding protein won't be produced. The stain has nothing to bind to, so that specific spot on the slide will be blank. We call that a loss of expression.
And what about the other test, the microsatellite instability, or MSI? How is that different?
MSI looks at the DNA itself rather than the proteins. We mentioned earlier that the mismatch repair genes act like a molecular spell checker. Well, scattered throughout our DNA are areas called microsatellites.
Okay, what are those?
These are just repeating sequences of DNA that are incredibly prone to copying errors. Imagine a typist trying to copy the letters CACACA over and over again perfectly.
Right, it's very easy to accidentally add an extra CA or leave one out.
Exactly. If the spell checker is broken, those repeating sequences get longer or shorter completely randomly as the tumor grows. That chaotic variation in length is what we call MSI high.
So it's basically a marker of chaos in the DNA.
Spot on. If a tumor is MSI high, it tells us the spell checker is definitely offline. And most Lynch syndrome tumors are MSI high.
Okay, so let's say we do the IHC stain. I want to look at the dimer partnerships, because this explains the specific staining patterns you see on a pathology report, and it's a concept that routinely confuses people.
It really does trip people up.
Because these 4 proteins don't work alone, right? They operate in pairs, like a molecular buddy system on the factory floor.
They absolutely do. MLH1 partners with PMS2 to form one working complex, and MSH2 partners with MSH6 to form another complex.
And they aren't equal partners, are they?
No, they're not. The fascinating biology here is that MLH1 and MSH2 are the dominant partners, or the senior managers of the complex. If the MLH1 gene is mutated, the MLH1 protein isn't made.
Which means the junior partner is left hanging.
Exactly. And without its dominant partner to stabilize it, the PMS2 protein basically degrades and disappears too. It goes home because its boss didn't show up.
That's a great way to put it.
So on the IHC stain, you will see a loss of both MLH1 and PMS2. The same goes for the other pair. A mutation in the dominant MSH2 leads to a loss of both MSH2 and MSH6 on the stain.
But what if the mutation is in the junior partner? What if PMS2 is the broken gene?
That's where the pattern changes. If the mutation is in the subordinate partner like MSH6 or PMS2, the dominant partner is strong enough to usually still form a stable protein on its own.
Ah, so the boss can work without the junior.
Right, so a mutation in PMS2 usually just shows an isolated loss of PMS2 on the stain, while MLH1 stays completely intact.
So you get the pathology report back on a patient's colon tumor. If it shows an isolated loss of MSH2, MSH6, or PMS2, the diagnostic pathway is pretty straightforward. You proceed directly to germline genetic sequencing, taking a blood or saliva sample to check the patient's actual inherited DNA to confirm Lynch syndrome.
Yes, that's the standard protocol.
But, and this is the crucial caveat that trips up so many surgical candidates on their FRCS exams, what happens if the stain shows a loss of MLH1?
That is the most critical juncture in the entire algorithm. If the MLH1 protein is lost on the tumor stain, you absolutely cannot jump straight to Lynch germline testing.
Why not?
Because the vast majority of MLH1 loss in tumors is actually sporadic, not hereditary. It's a localized accident that only happened in the tumor, not a genetic condition the patient was born with.
How does that even happen? How does the gene just randomly shut off in one spot?
It happens through a process called promoter hypermethylation. Imagine the promoter region of a gene is like a light switch. In these sporadic cancers, a chemical padlock, a methyl group, gets slapped onto the light switch, locking it in the off position.
Okay.
The MLH1 gene itself is perfectly fine. It has no mutation, but it can't turn on. This chemical padlocking is usually driven by a completely separate, non-inherited somatic mutation in a gene called BRAF. Specifically, the BRAF V600E mutation.
Somatic mutation, meaning a genetic typo they acquired over their lifetime, maybe from environmental factors or just bad luck, as opposed to a germline mutation, which is in every cell of their body from birth.
Exactly.
So because of this chemical padlock phenomenon, you have to do an intermediate step.
Precisely. If the IHC shows absent MLH1, your immediate next step is to test the tumor tissue for that VRAF V600E mutation or directly test for MLH1 promoter hypermethylation.
And if they find it?
If either of those are present, it strongly suggests the cancer is a sporadic, unlucky event and Lynch syndrome is essentially ruled out.
But what if they don't find the BRAF mutation?
If those are negative, meaning there is no BRAF mutation and no hypermethylation, so the light switch isn't padlocked, then you proceed to germline genetic testing for the MLH1 gene, because it's highly likely they actually have a true inherited mutation.
I have to play devil's advocate here. Yeah. Why are we going through this complex, multi-step tumor testing algorithm at all? Why do we test the tumor first instead of just swabbing everyone's cheek immediately for germline testing?
I get asked this a lot.
Right. I mean, the J-screen data highlights that clinical genetic testing is incredibly simple now. It just requires a blood or saliva sample, looks directly at the patient's DNA, and returns results in 2 to 3 weeks. Why bother with the intermediate tumor step and all this staining?
It's an excellent question, and it comes down to resource management, diagnostic clarity, and preventing false alarms. Remember, the rule is universal screening for everyone with colorectal or endometrial cancer.
And most of those aren't Lynch?
Exactly. The vast majority of those cancers are sporadic. Tumor testing acts as a highly sensitive, cost-effective filter. If the tumor shows all 4 mismatch repair proteins are present and it is microsatellite stable, the chance of the patient having Lynch syndrome is incredibly low.
So you save a lot of money and time.
You've just saved the healthcare system the cost of a full germline panel, and you've saved the patient weeks of agonizing wait time. Furthermore, if the tumor testing is abnormal, it tells the geneticists exactly which gene to look for.
Sounds like a treasure map for the lab.
Yeah, if the tumor is missing MSH2, the lab knows to focus intensely on sequencing the MSH2 and EPCM genes rather than hunting blindly through the entire genome.
But let's say the tumor testing does point to Lynch, and the patient takes the germline blood test and it comes back positive. You have to consider the psychological weight of this.
It's a huge burden.
If you get that positive result, it undeniably triggers immense anxiety. You now know you have a genetic time bomb. But it also opens the door to cascade testing for all first-degree relatives, parents, siblings, children.
That's the real power of it.
Right. That is where the true preventative power of this knowledge lies.
Yeah.
You aren't just saving the patient in front of you. You are potentially saving their entire family. On the flip side, what if the germline test is negative despite a strong family history? It doesn't mean the patient is completely risk-free, does it?
Not at all. A negative genetic test in a high-risk family just means we haven't found the specific typo with our current technology. There might be a mutation in a gene we haven't discovered yet, or a type of mutation our current sequencing can't detect.
So you still have to watch them closely.
They must still be managed clinically based on their family history. But for those who are confirmed to have a specific Lynch mutation, how we manage them has fundamentally changed in recent years.
Which brings us to the next big shift.
Yeah, 10 years ago, we used to treat all Lynch syndrome patients the exact same way. If you had the syndrome, you got the maximum, most aggressive screening protocol, regardless of which gene was broken.
But that's not the case anymore.
No, that monolithic approach has completely shifted thanks to a massive data collection effort called the Prospective Lynch Syndrome Database, or PLSD.
Here's where it gets really interesting. The PLSD paradigm has revolutionized this field by moving us from a syndrome-level approach to a gene-level approach. We now calculate personalized cancer risk assessments using specific gene data, gender, and age. It is no longer one-size-fits-all.
The PLSD has allowed us to establish a very clear, evidence-based genetic hierarchy of risk. MLH1 and MSH2 are the high-risk variants.
Oh, how are we talking?
For men with an NLH1 mutation, their lifetime risk of colorectal cancer can reach a staggering 53%. The risks for endometrial and ovarian cancers in women with these variants are also exceptionally high.
And the other genes?
Then you have MSH6, which sits in the intermediate category. But PMS2 is the true game changer in this new paradigm. It is significantly lower risk.
Like how much lower?
The lifetime colorectal cancer risk for a PMS2 carrier is only about 10 to 12%. And incredibly importantly, the data now robustly shows that PMS2 carriers are at no greater than average risk for developing ovarian cancer compared to the general population.
I want to illustrate this for you, the listener, to show exactly why this matters in the real world. Let's contrast two hypothetical patients. Patient A is a 30-year-old female who just found out she has an MLH1 mutation. Patient B is a 30-year-old female who found out she has a PMS2 mutation.
Okay, two very different scenarios now.
Right. A decade ago, a doctor would have sat them both down and told them they have an astronomical risk of colon, uterine, and ovarian cancer. We would have terrified both of them equally. Today, thanks to PLSD, our clinical response is completely divergent.
It's like night and day.
Exactly. Patient A with the MLH1 mutation needs aggressive, frequent colonoscopies. She needs a serious timeline mapped out for the risk-reducing surgical removal of her uterus and ovaries. Her anxiety is justified, and our clinical response must be vigilant.
And patient B?
But patient B with the PMS2 mutation, we can actually offer her massive reassurance. Her colon cancer risk is only slightly higher than the general population. She doesn't need a colonoscopy every single year. And we absolutely do not need to rush to surgically remove her ovaries and force her into early surgical menopause because her ovarian cancer risk is standard. We manage their anxiety and their physical bodies entirely differently.
That nuance is the very definition of precision medicine. It prevents the profound harm of overtreating patients with lower risk variants while ensuring absolute, unwavering hypervigilance for those high-risk carriers.
An amazing progress.
And speaking of vigilance, let's transition from the gastrointestinal tract to how we manage the sentinel cancers in women, the gynecological malignancies.
So we established that endometrial cancer is the most frequent sentinel cancer in women with Lynch syndrome. It often hits before the colon cancer does, acting as that early warning alarm.
It's very common.
The screening guidelines recommend an endometrial biopsy and a transvaginal ultrasound, or TVUS, every 1 to 2 years, starting between the ages of 30 and 35. For those unfamiliar, an endometrial biopsy involves passing a thin tube through the cervix into the uterus to suction out a tiny sample of the lining.
It can be quite uncomfortable for the patient.
Yes, very uncomfortable. But there is a massive, incredibly critical limitation we have to acknowledge here about this screening protocol. While it detects cancer, screening has not been shown to actually reduce mortality for endometrial or ovarian cancer in this population.
What's fascinating here is the reason behind that. I know that sounds counterintuitive. Why screen if it doesn't save lives?
Right, why put them to it?
The why behind that limitation is fascinating. It has to do with the biology of the disease and human behavior. Endometrial cancer usually presents early on its own with a very obvious, undeniable symptom: abnormal vaginal bleeding.
So the patients notice it themselves.
Because patients notice the bleeding and immediately seek care, the cancer is typically caught at an early, highly treatable stage, even without formal scheduled screening.
Oh, I see.
So while doing an annual painful biopsy might detect the cancer a few months before the bleeding starts, it hasn't actually translated into saving more lives overall because the symptom-driven detection is already so effective.
But doctors still offer the biopsy, don't they?
Yes, because the biopsy has excellent sensitivity up to 99%, and because the lifetime risk for MLH1 and MSH2 carriers is so extraordinarily high, guidelines still generally support offering it to patients who want to be proactive.
But if getting a biopsy every year doesn't definitively lower the death rate, what does? The answer is risk-reducing surgical options. Specifically, a prophylactic hysterectomy to remove the uterus entirely, and a bilateral salpingo-oophorectomy, or BSO, which is the surgical removal of both the fallopian tubes and the ovaries.
The impact of prophylactic surgery here is profound and absolute. A massive long-term study tracked patients with Lynch syndrome over 13 years.
What did they find?
Of the women who opted for a risk-reducing hysterectomy, exactly 0% developed endometrial cancer. The tissue was gone, so the risk was gone. Contrast that with the women who kept their uteruses. 33% of them went on to develop endometrial cancer during that same time period.
That's a massive difference, 33% versus 0.
It is the ultimate preventative measure. But the timing of this surgery is a complex, deeply personal, and highly fraught decision.
Because you're balancing the absolute prevention of cancer against the permanent loss of fertility and the immediate onset of surgical menopause.
Exactly.
For MLH1 and MSH2 carriers, where the risks are highest, prophylactic surgery is strongly considered once childbearing is complete, often recommended around age 40 to 45. But if a young woman in her 20s finds out she has a high-risk mutation and she wants to have children in the future without passing this genetic time bomb to them, how do we navigate that?
This is where we bring in the reproductive endocrinologists and leverage advanced fertility technology. We can utilize in vitro fertilization, or IVF, along with pre-implantation genetic testing, or PGT.
How does that actually work?
The process works like this. We stimulate the ovaries, retrieve the eggs, and fertilize them in the lab to create embryos. Then we take a few cells from each microscopic embryo and actually sequence their DNA.
So you can see the Lynch mutation.
We can see exactly which embryos inherited the broken Lynch mutation and which ones did not. We can then selectively transfer only the embryos that do not carry the mutation back into the patient's uterus.
That's incredible.
By doing this, we effectively halt the syndrome in that family line forever. It's an incredible application of science. Once the patient has safely completed her family using this method, she can then proceed with the risk-reducing hysterectomy and BSO to protect her own life.
Now, we mentioned this earlier, but it is worth repeating for anyone taking an FRCS exam because it is highly tested. Gene-specific nuances matter immensely when planning the surgery.
I can't stress that enough.
Yeah. While a BSO to remove the ovaries is standard protocol for MLH1 and MSH2 carriers, we manage PMS2 carriers completely differently. The data shows PMS2 carriers are at no greater than average risk for ovarian cancer.
Which changes everything for them.
Therefore, for a PMS2 carrier, removing the ovary should be highly individualized and generally deferred entirely. Maintaining natural hormones is critical for bone density, cardiovascular health, and cognitive function. We do not want to force a woman into early menopause if her genetics don't demand it.
Exactly. We must tailor the scalpel to the gene. And as we transition from gynecological management back to gastrointestinal surveillance, we see a stark, fascinating contrast.
In terms of screening efficacy.
Yes. While gynecological screening hasn't shown a mortality benefit, colorectal screening through colonoscopy has an absolute, undeniable, massive mortality benefit. It is the frontline defense that keeps these patients alive.
Let's get into the hard specifics of that frontline defense. The European guidelines from the EHTG and ESCP provide very clear, rigid protocols for colonoscopy intervals and start ages based on the specific gene mutations.
Right. It's very codified now.
For our high-risk MLH1 and MSH2 carriers, surveillance colonoscopies must start at age 25. The interval is every 2 to 3 years. For our intermediate and lower-risk MSH6 and PMS2 carriers, surveillance starts at age 35.
And what are the intervals there?
The interval is every 2 to 3 years for MSH6 and can be stretched up to every 5 years for PMS2. And importantly, this surveillance protocol does not differ between men and women.
Let's explain the why behind those specific numbers. Why wait until age 25 for the highest risk patients? If they're born with the mutation, why not start scoping them at 18?
Yeah, that's a common question.
The data shows that the risk of developing colorectal cancer before the age of 25 in Lynch syndrome is incredibly low. It hovers around 0.8%.
Which is almost negligible.
Right. And performing a colonoscopy carries its own risks: bleeding, bowel perforation, the risks of anesthesia. So starting at 25 perfectly balances the need for early detection with the physiological and psychological burdens of the procedure itself.
That makes perfect sense.
Now, regarding the intervals, there has been immense controversy in the field. You might logically ask, if MLH1 is so dangerous, why not do a colonoscopy every single year?
I was just going to ask that. If someone is getting a high-definition camera up there every 2 years and the doctor is meticulously snipping out every polyp they see, How are cancers still slipping through the cracks? Are these cancers just growing at warp speed?
That is precisely the mechanism. Carcinogenesis in Lynch syndrome is characterized by an accelerated adenoma carcinoma sequence.
Accelerated, like how fast?
In the general population, it might take 10 solid years for a small benign adenoma polyp to slowly accumulate enough mutations to grow into an invasive cancer. In a Lynch syndrome patient with defective DNA mismatch repair, that same progression from a tiny polyp to a full-blown cancer can happen in just 1 to 3 years.
Just 1 to 3 years. That's terrifying.
Remember, their molecular spell checker is completely offline. The mutations stack up exponentially fast. Because of this warp speed biology, massive studies tracked patients scoped every single year versus those scoped every 2 to 3 years.
And what was the outcome?
The results were shocking. Even when patients were scoped annually, they still developed what we call interval cancers, cancers that pop up between scheduled scopes at roughly the same rate and stage as those scoped every 2 to 3 years.
So more frequent scoping didn't stop it.
The incredibly fast growth means that catching it at year 1 versus year 2 didn't significantly alter the long-term survival statistics. Therefore, the medical consensus settled on the 2 to 3 year interval to reduce the massive burden of constant invasive procedures on the patient while still maintaining the life-saving mortality benefit.
And when the gastroenterologist is actually in there doing the colonoscopy, the visual technique matters tremendously. The guidelines heavily discuss the role of chromodoscopy.
Yes, that's a key tool.
For those outside the GI suite, this is where the doctor sprays a special contrast dye, like indigo carmine, onto the mucosal surface of the colon through the scope. The dye pools in the tiny microscopic crevices and highlights the subtle surface contours, making flat, pale, hard-to-see adenomas stand out vividly against the pink tissue.
It's like turning on a black light.
Exactly. While modern high-definition white light endoscopy is fantastic, chromoendoscopy is considered a powerful adjunct tool, especially in centers that might have lower baseline adenoma detection rates. It really helps ensure absolutely nothing is missed in these high-stakes patients.
And we absolutely cannot afford to miss anything, which brings us to a highly tested area regarding bowel preparation.
Oh yes, the prep.
For a colonoscopy to be effective, the colon must be completely flushed out and clean. If a Lynch patient comes in for their scheduled surveillance colonoscopy and the bowel prep is deemed not entirely adequate, meaning there is some residual fluid or stool obscuring the view of the colon wall, you do not say, "Oh well, see you in 2 or 3 years."
What you do?
You repeat the procedure in exactly 1 year. Furthermore, if the bowel prep is completely inadequate or the exam couldn't be safely completed, you do not pass go. You must request an immediate repeat procedure within 6 weeks.
6 weeks.
The accelerated warp speed biology of Lynch syndrome simply does not afford us the luxury of waiting.
So despite our absolute best screening efforts with high-definition cameras, special dyes, and perfect bowel prep, a patient still develops a primary colonic cancer. We have now arrived at the surgical battlefield and the critical decision-making that is heavily tested on surgical exams and agonizing in practice.
This is where things get really complex.
We have to decide between 2 radically different approaches: an extended resection versus a standard segmental resection. Can you define what those terms actually mean for the patient's anatomy?
Absolutely. Let's say the tumor is in the right side of the colon. A standard segmental resection means we just take out the right side of the colon, the part with the tumor, and we connect the small intestine to the remaining left side of the colon.
We call that an anastomosis.
Right. We leave the vast majority of their large intestine intact. An extended resection, however, means a subtotal or total colectomy. We remove the entire colon from the appendix all the way down.
And then
We then take the end of the small intestine, the ileum, and plumb it directly into the sigmoid colon or the rectum. This is called an ileosigmoidal or ileorectal anastomosis.
that is a massive anatomical difference. With an extended resection, the patient loses the entire water-absorbing function of the large intestine. They will go from having 1 or 2 normal bowel movements a day to having 4, 5, or 6 loose bowel movements a day for the rest of their life. It's a huge hit to their daily quality of life.
It's a major lifestyle change.
So why would we ever choose to do an extended resection if a smaller one removes the cancer just fine?
This decision is entirely dictated by the heavy burden of metachronous cancers.
Explain metachronous for us.
A metachronous cancer is a new primary cancer that develops in the remaining colon tissue months or years after the first cancer was successfully removed. It's not a recurrence of the first tumor. It's a brand new tumor starting from scratch.
Okay.
In our high-risk MLH1 and MSH2 carriers, the risk of developing a second metachronous colon cancer is staggering. It is up to 36% by age 70 if you leave the rest of the colon inside them.
36%.
Because of that massive looming risk, the definitive guideline for MLH1 and MSH2 carriers is that extended surgery, removing the entire colon, is preferable for their first colonic cancer diagnosis. You remove all the tissue that is at risk.
So what does this all mean in a practical sense? Think of it like finding a spot of mold on a slice of bread. For a standard non-Lynch patient who gets colon cancer, it's just an unlucky spot of mold. You can safely cut off that one moldy edge. That's your standard segmental resection. But for an MLH1 Lynch patient, the entire loaf of bread is genetically predisposed to growing mold rapidly. If you just cut off the one moldy slice, the next slice is almost guaranteed to grow mold soon. So, to be safe, you have to throw out the whole loaf. That is your extended resection.
That analogy perfectly captures the surgical rationale. The data proves it. Extended surgery reduces the risk of a second colon cancer by up to 4 times compared to just a segmental colectomy.
But there's a catch, right?
However, and this is a very important nuance, when a surgeon is counseling, a patient extended surgery has not been proven to significantly improve overall survival compared to segmental surgery, followed by rigorous annual colonoscopy of the remaining bowel.
So they live just as long either way.
Yes. Therefore, this becomes a deeply personal, agonizing quality of life decision. The patient has to weigh the daily functional burden of a total colectomy against the immense psychological burden of knowing they have a 36% chance of needing another major cancer surgery in the future.
Now let's contrast that with the MSH6 and PMS2 carriers. Because their lifetime risks and metachronous cancer risks are so much lower, the guidelines recommend a standard segmental resection for their first colonic cancer.
Exactly.
We absolutely do not throw out the whole loaf for a PMS2 carrier. And what about rectal cancer? If the primary cancer is located down in the rectum, the guidelines recommend a standard resection, either an anterior resection or an abdominal cranial resection, which involves removing the rectum and anus entirely and leaving the patient with a permanent stoma bag.
That is the standard across all gene mutations.
Although, for very young patients with a rectal cancer, an extended surgery like a proctocolectomy with an ilioanal pouch can be considered.
And if we are talking about ilioanal pouch procedures, where we remove the entire colon and rectum and build a fake rectum out of folded small intestine, the guidelines are incredibly strict.
Because it's a tough surgery.
These are complex, high-morbidity surgeries with a steep learning curve. They absolutely must be performed in highly specialized colorectal surgical units that perform a high volume of these specific procedures.
What's considered high volume?
The guidelines define high volume as more than 10 pouch procedures per year, and they must follow European Crohn's and Colitis Organization, or ECGO, guidelines. High-volume centers have drastically lower pouch failure rates and much better pouch salvage rates if something goes wrong.
Let's pause here and summarize the top 5 common errors made during the surgical management of Lynch syndrome. If you're taking an FRCS exam, write these down.
Definitely pay attention to these.
Here are number 1, prophylactic bowel surgery. You might look at the high cancer risk and think, why don't we just remove the colon before any cancer even starts, like we do in familial adenomatous polyposis, or FAP? The guidelines are crystal clear. Prophylactic bowel surgery in the absence of neoplasia is not recommended for Lynch syndrome.
Right. You do not cut until there is a cancer or a massive polyp that can't be removed through a scope.
Here, number 2. Deciding to do an extended total colectomy based solely on an endoscopic biopsy that shows a loss of MLH1 on an IHC stain. Remember what we said earlier?
Most MLH1 loss is sporadic due to BRAF mutations.
You must confirm the germline Lynch diagnosis before you commit a patient to losing their entire colon. Error number 3. Giving a PMS2 patient a total colectomy. Their risk doesn't warrant it.
Keep their colon intact if possible.
Error number 4. Ignoring extracolonic symptoms, like dismissing abnormal vaginal bleeding in a patient with a known colon cancer history. And error number 5. Failing to test the tumor first before blindly ordering expensive germline panels.
That is a perfect summary. Do not let the urgency of a cancer diagnosis force you into an irreversible surgical decision without having the complete, nuanced genetic picture.
Right.
And as we move beyond the surgical battlefield, we arrive at what is arguably the most empowering, optimistic aspect of modern Lynch syndrome management: lifestyle interventions, chemoprevention, and the patient taking back control.
This is where we shift the narrative. A Lynch syndrome diagnosis feels like an absolute genetic destiny, But it isn't absolute. We actually have a powerful, incredibly cheap, over-the-counter weapon in our arsenal: aspirin.
Aspirin is incredible here.
The CAPP2 and CAPP3 studies have completely changed the game. Taking a daily dose of aspirin has been proven to significantly lower the risk of developing colorectal cancer in Lynch syndrome carriers.
The story of the CAPP trials is incredible. It took researchers like Professor John Byrne decades and tens of thousands of patient years to prove this, because the protective effect takes a long time to show up in the data.
How does it actually work?
The mechanism is fascinating. Aspirin chemically alters the environment that these rapid growth tumors need to thrive. It likely works by reducing chronic mucosal inflammation in the gut and modulating the local immune response, making the colon a highly hostile environment for a rogue cell to grow.
And what's the recommended dose?
The protocol recommends a minimum of 75 to 100 milligrams of aspirin daily. And importantly, the newer CAP3 study highlighted that the dose should be scaled based on the patient's BMI or body weight. Heavier patients may need a higher dose to achieve the same protective effect.
But I want to stress, it's not a magic pill that works overnight. You can't take it for a week before your colonoscopy and expect to be clean. The data is clear that the patient must take the aspirin continuously for at least 2 years and ideally 5 years for the protective biological effect to truly kick in.
It's a long-term commitment.
Therefore, the clinical guidance suggests starting the daily aspirin regimen 5 years prior to the recommended age for their first surveillance colonoscopy. So for our high-risk MLH1 and MSH2 carriers who need to start their colonoscopies at age 25, they should ideally start taking daily aspirin at age 20.
If we connect this to the bigger picture, beyond aspirin, we have other heavily modifiable risk factors that the patient can directly control. Physical activity has been proven to independently reduce the risk of colorectal cancer in carriers.
It gets the bowel moving.
It gets the bowel moving and reduces systemic inflammation. On the flip side, smoking, obesity, and heavy alcohol consumption significantly increase the risk. Think of it this way. The genetic mutation loads the gun, but lifestyle factors can absolutely pull the trigger. We also must proactively screen for and eradicate a specific bacteria in the stomach called Helicobacter pylori.
Why H. pylori specifically? How does a stomach bug interact with a broken genetic spell checker?
It's all about inflammation again. H. pylori causes chronic, simmering inflammation in the stomach lining. Inflammation demands rapid cell turnover to heal the tissue.
And rapid cell turnover means copying DNA.
Exactly. Rapid cell turnover means the DNA copying machinery is working overtime. If you force a system with a broken spell checker to work overtime, the chance of a critical genetic typo occurring skyrockets.
Because they already have an elevated baseline risk.
Because Lynch carriers already have an elevated baseline risk of gastric cancer, clearing out an H. pylori infection with a simple course of antibiotics removes a major, easily treatable inflammatory driver of that specific cancer.
It is incredibly empowering. It shifts the patient from being a passive victim waiting for cancer to strike to an active participant in their own survival. And that brings us to the core takeaways of this massive deep dive. If you remember nothing else from this discussion, lock these high-yield points into your brain.
Number one is definitely universal screening.
Yes. Number one, universal tumor testing is the modern key to identifying these patients. Do not rely solely on those flawed, Balser-like family history criteria. Number two, the PLSD database has personalized the risk landscape. An MLH1 carrier and a PMS2 carrier are fighting completely different battles and need completely different surveillance.
That's a huge point.
Number three, the extent of your surgical resection for colon cancer depends entirely on which specific gene is mutated. And number four, a cheap daily aspirin is a literal game changer for cancer prevention in this population.
Mastering these complex guidelines is not just about passing your FRCS exam or staying casually informed on the latest journal articles. It is about fundamentally altering the trajectory of a human being's life. When you understand the biology, when you catch a Lynch syndrome diagnosis early through tumor testing, and when you apply the right surveillance and the right surgical intervention at the exact right time, you are literally preventing a tragedy before it has a chance to strike. You are giving a family their future back.
And as we wrap up, I want to leave you with a final provocative thought to mull over. As genetic sequencing technology continues to advance, becoming as cheap and accessible as a standard blood test, we are rapidly approaching a world where universal population screening might replace our complex algorithms entirely.
That's a profound thought.
Imagine if every single person knew their genetic blueprint from birth. If we swabbed every baby's cheek in the hospital, would we eradicate Lynch-associated cancers entirely through perfect lifelong surveillance? Or would we simply replace physical illness with a lifetime of crippling psychological anxiety, forcing millions to wait for a genetic time bomb to go off? As our technology outpaces our psychology, it's something to think about. Thank you so much for joining us on this deep dive. Keep questioning the algorithms, keep learning the underlying biology, and keep cutting to the core of the issue.